Hi there, my name is Dr. Amara Sohail, and I'm one of the obstetrics and gynecology consultants working at Basingstoke Hospital NHS Foundation Trust. I have been asked to give you an overview on a couple of topics. One of them is female urinary incontinence, and the other one is female genital prolapse. So I'm just hoping that it will suit your requirements, and it shouldn't be too complicated because I've kept it very simple. So what we are hoping to achieve today is for you guys to understand the types of incontinence and discuss the approach to a patient who presents to you with history of urinary incontinence, to identify what key investigations should be offered, and then at the end treatment modalities or management plan. So first of all, I would like to give you a definition of what a urinary incontinence is all about. So urinary incontinence is defined as involuntary loss of urine that is objectively demonstrable significant impact on the quality of a woman's life. So one may say that it could be a symptom, it could be a sign or a condition on its own. And anyone who presents with a history of urinary incontinence, there are certain risk factors that we'll go through later on. It is important to mention that the risk of urinary incontinence increases with age. And of course, this problem could have a significant impact not on the psychological well-being of a woman, but it also involves the cost, because women may have to wear pad or they may need to change their clothes time and time again. And it is understandable that when a woman goes through this kind of a situation, it can be quite embarrassing. I mean, for us working in a hospital environment or elsewhere, in office or in a business, you are in the middle of a meeting and you start leaking urine. It is very embarrassing, and not only embarrassing, it will of course like intimidating for the patient. So it is something which has got a huge impact on a woman's life, and therefore it is very important to take into consideration to understand what it's all about. So prevalence is, I mean, as I've already alluded to, that it is a very common problem which the incidence increases with age. And the risk of urinary incontinence between the age group 15 to 44 is only 5%, but as the age goes up, the incidence may go as high as 20% after age 65. And I mean, nowadays when people live longer and average lifespan of a woman is definitely in 80s, living with this problem for 10, 20 years, it is absolutely not acceptable. So it would significantly reduce the quality of women's life by affecting the physical health as well as the psychological health and social well-being of the patient. So what are the risk factors? I mean, one of the main role of a woman is to produce children. So one of the major risks is the damage that is incurred during childbirth. So after the delivery of the child, it is very important to emphasize on the importance of pelvic floor muscle exercises because a significant damage may occur during childbirth, as well as there is a damage to the nerve supply that supplies the urethral sphincter as well as the pelvic floor. With age, why does the incidence increase? It is because of the atrophy of the tissue due to the lack of estrogen receptors. So in menopause, which is cessation of a woman's reproductive life, there will be less estrogen and hence the tissue elasticity is lost, which may cause the breakdown of the tissues, resulting in incontinence. And then connective tissue or collagen problems. Women who are oviparous, they can also have it, and that could be due to their genetic predisposition to having abnormal connective tissue or collagen. And another important thing to remember is that Black women, they've got high quality connective tissue, therefore they have got less risk of having incontinence problems. And then women who suffer from conditions like chronic cough or COPD, or if they have anything that leads to constipation where they have to strain, these are the things that can also lead to significant incontinence. Obesity is also a major factor, and smoking increases the risk of urinary incontinence by 2 to 3 times by affecting the quality of the tissues. So other risk factors, radiotherapy, women who have got history of cancer, if they underwent radiotherapy, radiotherapy can cause fibrotic damage of the bladder in half of the women. So that is also a major risk factor. In addition to that, neurological conditions like MS, which may lead to increased frequency and urgency, may have significant issues causing incontinence in women. Likewise, Parkinsonism, and again, as I previously said, age-related. So what are the complications of urinary incontinence? I would like to emphasize more and more on the psychological impact, which is basically embarrassment that it causes to the women by sudden leakage in front of a group of people. That results in social isolation. So women try and avoid going to places where they may have such accidents, or even if they go, they first of all, they make sure they want to locate the toilets so that if they need, they don't have any difficulty approaching it, and in order to avoid the accidents. And also, because of all these psychological impacts, it may cause issues as falls because women are rushing. And then, as I said, avoidance of social settings. And women, they are reluctant to have sexual intercourse because, again, there is an element of embarrassment and soiling. And then there is also a possibility of urine infection. And the constant dribbling or incontinence may lead to damage to the skin and may result in inflammatory skin diseases in the form of dermatitis. So what are the types of incontinence? The commonest types that we come across whenever there is someone who presents with urinary incontinence, there is stress urinary incontinence, urge urinary incontinence, or a mixture of stress and urge. And then there are other types of incontinence which could be functional, or sometimes when girls or women, they giggle, they leak. Sometimes there is an obstructive damage which can lead to the overfilling of the bladder, and that overfilling may lead to the spillage, as well as sometimes coital incontinence. Again, that could also have some neurological involvement, and then a transient. So my focus would be mainly on stress, urge, and mixed incontinence, because the rest of them, the names suggest they are self-explanatory, so it doesn't need elaborating much. So what is stress urinary incontinence? In stress urinary incontinence, the leakage is preceded by effort or any kind of activity, which is physical activity like jumping, trampolining, walking, or exercise. So leakage happens after there is any activity. However, in urge incontinence, leakage is preceded by urgency. So women get a desire that they want to go, whether or not bladder is full, they get the urgency, and if they are not very close to the toilet, they would leak. So there is no control whatsoever. In stress urinary incontinence, women can control the leakage by sometimes crossing the legs because it is a structural abnormality. And what is the urgency? Urgency is the compelling desire to void, which cannot be deferred. So, you have to understand the difference between the stress urinary incontinence and urge incontinence, because the cause of both is also very different. And why a mixed urinary incontinence is important? Because bladder is a poor historian. So when you ask questions from women, they may not be able to differentiate between what stress incontinence means and what urge incontinence, because to them, leakage is leakage, whether it happens after an activity or it's after a desire. Urge incontinence could be a symptom of overactive bladder, where women experience frequency, nocturia, and urgency. So what is the pathophysiology? As I've already mentioned, stress urinary incontinence results from a structural or anatomical damage. And what happens in the structural or anatomical damage is that there is a descent of bladder neck or proximal urethra. So normally, in order for women to stay continent, certain forces are acting around the pelvic floor. And they are a combination of pressures within the abdomen, within the bladder, within the urethra, supported by all the pelvic floor muscles. So when there is any anatomical disruption, it would lead to change in the pressure gradients, and as a result, the normal continent function would be disrupted, resulting in the leakage. And likewise, sometimes what happens is that the intraurethral pressure would be lower than intravesical pressure. And you can imagine that when the bladder is filling and the pressure or diffuser pressure is rising, the intravesical pressure should be lower than intraurethral pressure in order to avoid leakage. However, that equilibrium will be disrupted in patients who present with incontinence. And that could result from urethral scarring or lack of estrogen, which happens when a woman achieves menopause. And then, as I mentioned, lack suburethral support also results from pelvic floor injury, which can happen after childbirth or any trauma in that area. So how do women present? They will come to you complaining of involuntary leakage on coughing, laughing, or sneezing, or there is a serious complaint of leakage when they are having sexual intercourse. They may have associated prolapse symptoms, which could be a lump in the vagina or a dragging sensation, etc. So it is very important to explore other symptoms, which are mainly urgency, which is the unavoidable desire to go, or frequency as well. Because sometimes women, they give you a completely mixed picture where you are unable to identify whether it is stress urinary incontinence or overactive bladder. So symptoms of overactive bladder, they're quite specific, because women will complain they go a lot, and that going a lot could be a result of urgency, or it could be because women, they do not allow the bladder to fill up enough to be able to have this desire to void. So that is why they keep going to the toilet. But urgency is a sudden compelling desire to void, which they cannot defer, as I have previously mentioned as well. And then urge incontinence is associated with the leakage with urgency. So in stress urinary incontinence, usually that symptom may not be there. But again, it can be very confusing when you ask the women these questions. And nocturia, again, is the same thing that happens during the nights. Women have to have several trips to the toilet to keep the bladder empty, or if they have got unavoidable desire to void. So we call the terminologies that we use is latchkey urgency or toilet mapping. And latchkey urgency is that a woman has got sudden compelling desire to void, and she's outside the house. She puts the key in the door and leaks because she doesn't have enough time to be able to make to the toilet. Even if they are in a social setup or something like that. So Overactive bladder syndrome is a triad of frequency, urgency, nocturia, or sometimes it could be plus minus leakage. So all these things, they are interconnected. So again, as I mentioned before, it is very, very important to try and differentiate the presenting complaints, because when you start taking a history, you have to make a differential diagnosis. And all these questions, they are very, very relevant. At the end of the day, women may find it very confusing when you ask them bladder-related questions. So eventually, in order to make the proper diagnosis, we have to offer them urodynamics, because the detrusor overactivity is a urodynamic diagnosis, because you cannot physically demonstrate it without having a proper test. And because overactive bladder syndrome or overactive bladder is one of the major problems, more than stress urinary incontinence. And because the treatments are completely different, you have to identify the problem prior to offering any management to the women. So other symptoms that could be associated with urinary incontinence are, women may complain of incomplete emptying. So that means that when they sit on the toilet to empty their bladder, they feel it's all empty, but when they stand up, they still have that desire to go again, so they sit again. So there is double voiding, because they want to have the sensation that they have completely passed the urine, and unless they do it again, they will not be able to achieve that. And then there is also a history of poor flow of urine. And poor flow is how women describe is that when they've got a desire to go, they sit on the loo, they're trying to empty the bladder, but only a small streak of urine is coming away. Sometimes that is also complicated by starting of the urinary flow. And that actually is an indicator that there could be some kind of obstruction, which is not allowing the free flow of the urine. So then if they are unable to completely empty their bladder, that may lead to recurrent UTIs. And all this can again be associated with the symptoms of prolapse, because prolapse may cause some obstruction into the urethral passage, resulting in all the symptomatology, whether it is incomplete emptying, poor flow, or other voiding difficulties. And they may have difficulty with sexual function, especially if they have got any underlying anatomical problems in the form of prolapse. So in addition to that, sometimes women, they also have a complaint of fecal incontinence or constipation, and all that may tell you a good this is a good indication that there is a possibility that there could be a prolapse having an impact on their avoiding function, leading to incontinence. So what are the right questions you need to ask? It is very, very important to investigate it fully before you start making a management plan. So the commonest question you should be asking is, if a woman goes to the toilet more than 8 times a day. I mean, if you think about the intake of fluid per day, it's approximately 2 to 3 liters a day. And that includes the water they drink, the tea or coffee they drink, or any other fizzies, etc. But it is a myth that 2 to 3 liters a day is is essential, because that all that does is that women, they drink a lot of water as they think that it is good for skin or for kind of giving them some a good texture of their body tissues, etc. But actually it's not correct. There is evidence to support that it is the daily requirement of fluid for an adult is between 1.5 to 2 liters. And a lot of that could be contributed from the food they take. So it is very essential that you inquire this question. And then asking about the number of times they wake up during the night to empty the bladder. Or the question about, do they have to rush to the toilet in order to avoid the leakage, and how many times they are unable to achieve that? What is the number of accidents that may happen during the day or night? And then, very importantly, do they leak with coughing, sneezing, walking, or exercises? And then the question about, do they feel that they have a sensation of incomplete emptying, or they feel that they have completely emptied the bladder? Or if they experience any pain when they're passing urine, or if they have ever noticed any blood in their urine. In addition to that, again, bowel symptoms, mainly the constipation, is very, very relevant. So in the assessment, we have already discussed the symptomatology and the questions you need to ask, which includes bowel, sexual behaviors, as well as the prolapse symptoms. Then women who have given birth before, it is important to inquire about the number of pregnancies they have and the mode of delivery, as well as the size of the largest child. And why the size of the largest child is relevant is because women who have achieved vaginal birth and given birth to a big baby, during the passage through the birth canal, a lot of tissues, they may get damaged during that passage. So if a woman has given birth to a 5-pounder, the risk of damage will be less than if the baby weighed 10 or more than 10 pounds, etc. In addition to that, medical history is very relevant. Women who have got history of diabetes, because they feel thirsty, they drink more and they produce more urine. So polydipsia, polyuria, that is very relevant. And then neurological conditions, any problems and related to their neurological systems, i.e. MS, etc., they can cause incontinence problems. And then depression. So women who are on antidepressants, this is a side effect of antidepressant drugs, that they may produce more urine. And of course, like women who have got history of any mental health illness, for them it is kind of an unacceptable thing for them to use the toilet a lot, and there is always a background history of incontinence at some stage in their lives. So the key points are fluid intake, the number of times they go to the toilet, if they, in the fluid intake, what fluids they take, because it's a well-known fact that caffeine, fruit juices, and fizzy drinks, they act as bladder irritants. And for women who do not have any bladder problems, they can drink as much as they want. However, when there is a problem with the bladder, women should be advised to avoid caffeinated and fizzy drinks, because then it's not helpful at all if you're trying to sort them out and they continue to drink this kind of stuff. Smoking, by causing damage to the tissues, will also to advise anatomical disruption or incontinence as a result of rise in the intra-abdominal pressure. So women who are taking diuretics for blood pressure problems or any other medical illness, they will, it is very important to take the note of that as well. So when you are examining a woman, like, it's no brainer, the most important thing is the general physical examination, which includes a woman's BMI or how she walks. Because if you notice that there is a limp or there is discomfort, that will give you a lot of hint about what the problem could be. And very, very important to offer abdominal examination, because if you, on abdominal examination, if you feel that the bladder is palpable, that will give you an indicator that there could be some kind of an obstruction, and which may be resulting in overflow incontinence. So abdominal examination is very, very important. Additionally, on abdominal examinations, you may actually make the diagnosis of a pelvic mass, because a woman who comes to you with incontinence, it may be happening because they've got a huge mass sitting in the abdomen, which is pressing on the bladder. So there may not be any urological problem. In fact, the problem could be exaggerated by the presence of a pelvic mass. So it is very, very important to do that. So during pelvic examination, you look for signs of vaginal or vulval atrophy, excoriation as a result of constant dribble, and then you ask them to perform the cough test, which will give you an idea of whether or not this could be a case of stress urinary incontinence, because women who leak on cough, that is a very good indicator that there may be an anatomical disruption, and then of course like identification of the prolapse. In addition to that, rectal examination. In gynecology, we don't always do rectal examination, but it is very, very important because sometimes on superficial examination through the vagina, you may not be able to demonstrate a prolapse. But when you do a PR examination, not only it tells you the tone of the anal canal, but there is a possibility you might be able to find the pouching in the back wall, which would tell you that there, even though the prolapse was not identified on the vaginal examination, but there is a prolapse because you will feel the absent connective tissue or deficient connective tissue. And also that will also give you an idea of stool consistency, which can also represent problems other than urogynecological. So neurological examination, I've already said, it is very, very important, and the neurological examination starts when a woman walks through the door. So what investigations are relevant? First of all, you want to rule out a possible infection in the waterworks. So urinalysis can be done there and then. So if urinalysis does not show any positive signs, then no problem. You have almost like in majority of cases, you have ruled out possibility of urinary tract infection leading to incontinence. But if the urinalysis gives you positive proteinuria or nitrites or other indicators of infection, then it's very important to send the urine for culture and sensitivity. You will also ask a woman to keep a bladder diary, and I'll show you what bladder diary means. And then when you are investigating them, if a woman is wearing a pad, either you'll be able to smell the pad or you'll be able to demonstrate the amount of urine that the pad has got to give you an idea or the extent of the problem. So the most important investigation is urodynamics, and especially as I previously mentioned, the treatment of overactive bladder is medical. The treatment of stress urinary incontinence is surgical. If you do not know exactly what the problem is and offer surgery without making sure that there is no element of detritus or overactivity, there is a 10% risk of de novo overactive symptoms after the surgery. So that is why it is very important from medical legal point of view that you know whether the problem of overactive bladder was pre-existing or it happened after surgery. And if other important things are urodynamics also. If it indicates that the woman may have mixed incontinence, which includes stress urinary incontinence and overactive bladder, it might be worth trying them anticholinergic treatment prior to offering incontinence surgery. The reason for that is because then you would know and you will be able to identify the success rate of the procedure you're going to be offering. And bear in mind, those who have previously had continence surgery, they may have forgotten about it, but on examination, it is very important to exclude that as well. So if on abdominal examination, you suspect that there could be a mass which is contributing to this problem, then it is important to offer them ultrasound scan. Women who have recurrent UTIs, it's vital to investigate and exclude a lesion within the bladder, which could be resulting in recurrent UTIs. So cystoscopy is an essential thing to exclude any underlying pathology in the form of malignancy, etc. And with regards to ultrasound scan, when you offer ultrasound scan, it might be worth considering a renal ultrasound scan if a woman has had a history of recurrent UTIs to exclude renal scarring. And then blood tests to make sure the woman is not diabetic, because sometimes women may not be aware of it. So if you have any suspicion from the history that there is a possibility of underlying medical condition, it is very important to as I previously mentioned, very important to differentiate between the two problems from the history, from bladder diary and urodynamic study. And this is how the bladder diary should look like. So what you ask the woman to record is the amount of fluid they take throughout the day, and then see how many times do they go out, and they're asked to measure the volume of the urine they produce. As well as the episodes of leakage during the day or night. Then the urodynamics includes uroflometry. And what we are trying to do in that is measurement of the urine flow rate. So if the flow rate of the urine is less than 15 mils per second, that is considered abnormal. It should be more than that. And if they void more than 150, that will be a reliable flow rate. But at the end, you would also check the residual, because if the residual is more than 50 to 100 mils, that indicates incomplete emptying. And it is very important to check the flow rate in order to rule out any voiding dysfunction, which could be neurological. And again, as I said, prior to surgery, all these investigations are very, very relevant. So in the cystometry, what we do is we measure the abdominal intravesical and intravesical pressure while the bladder is artificially filled. And during the filling, we do ask women to try and cough or sneeze to see if there is any leakage, and then ask them when they get the first desire to void. And what you will notice is that women who suffer from overactive bladder, the pressure, the intravesical pressure starts to rise even with the small volume of urine in the bladder. In extreme cases, sometimes women get the first desire to void even with 50 mils of bladder. And for a normal female, the bladder capacity is between 400 to 600 mils. And if a woman gets the desire to void with 50 mils, you can understand how bad the problem is. So we then measure the detrusor pressure, which is a result of subtracting intravesical pressure from the intra-abdominal pressure, which is measured during cystometry. So the important parameters during the urodynamics is to look at the detrusor pressure on filling, the capacity of bladder, the sensation and desire to void, the episode of leakage, and that will help you to differentiate whether it is stress or overactive bladder. So with the diagnosis, how we make the final diagnosis is we call it urodynamically proven stress incontinence if there was leakage on increased intra-abdominal pressure in the absence of rise in detrusor pressure. However, with the overactive bladder, what you notice is there will be a spontaneous or provoked detrusor contractions even with small volumes. So how do we treat? The treatment, again, could be conservative, it could be medical or surgical. And that also depends on whether a woman has got stress urinary incontinence, overactive bladder, mixed incontinence, or dysuria or other voiding problems. So the treatment will be based on your assessment and the final diagnosis, which will be made on the basis of all the investigations you have carried out. So in conservative management, what you do is you remove the risk factors, where ask the women to avoid all those things that will contribute to the incontinence, which includes the fluid intake, bladder retraining, avoidance of toilet mapping, because then it becomes a habit. Just like if you think about the new children who are having their training, bladder training, they are asked to empty the bladder when they're going out, so that they don't have any accidents or a leakage while they're out. That actually spoils their habits, because then there is automatically women, they do have a desire to keep the bladder empty, which is not good. So bladder retraining is very, very important. And then it is important to review the current medication. If there are any medicines women are taking that may have a side effect of diuresis, then you will try and find an alternative treatment for them. And then counseling is very important, because you don't want to give them unexpected, you don't want to give them false expectations. So it is very important to emphasize on the realistic goals that one can achieve, whether it is conservative, medical, or surgical treatment. So for the treatment of stress urinary incontinence, it is very important to offer pelvic floor exercises, because a lot of times the problem could just be a weak pelvic floor. And in the majority women that are in the younger age group, with the just pelvic floor exercises, there is 60% or more improvement. Or you can add continence pessaries depending on the desires of women, but continence pessaries, they are not suitable for women who are sexually active. In surgical treatment, there are different surgical treatment options, which include slings. TVT has been a very well recognized surgical treatment, but unfortunately, you must have heard about the controversies regarding to the use of meshes these days. So it's almost put on hold, because women have complained of mesh erosions and serious side effects as a result of tapes that had been put in for several years ago. So in UK and in some European countries, the meshes are put on hold. Colpo's suspension, it is a historical treatment that we have always offered, and it has now come back into practical practices these days because of the problem with the TVTs and TOTs. And then bladder neck injections, these are temporary measures. I'll just show you the pictures of how a TVT, if you see here, you can see where the tape is running. So in transvaginal tape procedure, it's like a Velcro sling, which is put around the bladder neck, around the urethra. So when a woman coughs or strains, it just acts as a sling and prevents the leakage. TOT is a transobturator tape, but TVT is more there is more evidence of its effectiveness compared to TOT. But both procedures, they are not done as widely as they used to be. Bladder neck injection, as you can see the picture, these are bulking agents in order to produce some kind of a constriction to avoid the leakage. But the problem with the bulking agents is that they have to be repeated. And sometimes one of the side effects of that is that women may go into urinary retention because there is too much bulking agent injected. So one has to be very careful. Treatment for overactive bladder is, again, avoidance of irritants, and smoking, loss of weight, bladder retraining, and then anticholinergics. There are several in market. So oxybutynin and tolterodine are the most commonly used, but the problem with the medical treatment is that they may cause, due to their anticholinergic effect, they may cause dryness of mouth, constipation, and dizziness, or drowsiness, and especially for elderly women, it's a very kind of undesirable side effect. So it's worth trying vaginal estrogens because restoration of the vaginal moisture can also help. And vaginal receptors are also present inside the bladder. So sometimes local or topical estrogen can also restore their normality and is very helpful. And similarly, which is a fairly new drug called mirabegron, which is a beta-3 adrenoreceptor agonist, has been in use. And I am not too sure about how effective it is, but it is in the market and it's worth using. So in the surgical treatment, which is nowadays very, very commonly used, is the Botox or nerve stimulation. So nerve stimulation has not gained as much popularity as the Botox. With Botox, again, it is toxin botulinum, which actually causes paralysis of the detrusor muscle by the release of this toxin. But and it is very good for women with overactive bladder because it kind of causes the paralysis of the muscle. But the side effect of that could be that women may go into retention and may have to do intermittent self-catheterization after that. So this is just like how we offer conservative management of overactive bladder or urge incontinence. Again, it's basically re-emphasizing on what we have already discussed, so I'm not going to go into the detail again. So I think I will stop here. Thank you very much for listening.